How has vitiligo been recorded and treated throughout the ages? How do you perform mini punch grafting in vitiligo? Welcome to the EADV Podcast. In today's episode of the EADV Podcast, Dr. Sarah Walsh is joined by Professor Koushik Lahiri, Professor and Senior Consultant Dermatologist of the Apollo Multi-Specialty Hospital in Kolkata, India. Together they delve into the fine art of mini grafting in vitiligo. They discuss how this condition has been recorded and treated throughout history and discuss the impact it has on a patient's quality of life. They also talk about the assessment criteria for patient selection and the expected longevity of the procedure. But before we get into that,
applying for EADV membership allows you to become part of a vibrant international community of professionals and gives you access to a variety of benefits and tools to deepen your knowledge while remaining up to date in your latest findings in your specialty. You're just 2 steps away from becoming an EADV member. Apply today. Visit EADV.org if you wish to learn more.
Join Dr. Sarah Walsh and Professor Lahiri as they share clinical tips and lessons learnt over the past 30 years of mini punch grafting in vitiligo and to learn more about this cutting-edge treatment option. Enjoy.
Hello and welcome to this edition of the EADV podcast. My name's Sarah Walsh. I'm a dermatology consultant working at King's College Hospital in London, and it's a great pleasure and privilege for me to be joined today by Professor Koushik Lahiri. Koushik is a professor and academic at the Apollo Hospital's Education and Research Foundation and also senior consultant dermatologist at the Apollo Multi-Specialty Hospital in Kolkata. He's got a number of important clinical academic positions, but also he's the director of the International Society of Dermatology and is the president-elect of the Indian Association of Dermatology, Venereology and Leprology. His major clinical interest in recent years has been in the domain of vitiligo. And he has made some significant publications in this domain. But as I was reading your biography, I thought it would be useful for our listeners, Professor Lahiri, to hear a little bit about your training and your background and what led you to the clinical field you are working in today. Over to you.
Thank you, Dr. Walsh. It's really an honor for me to be invited as a guest speaker in EADV Podcast with you as the host. I was trained in Burdwan Medical College. Burdwan is actually was a princely state in the eastern part of India, about 63 miles from the state capital of Kolkata, or Calcutta as we used to call her then. And you may be interested to know that my father was also a dermatologist, and he was instrumental in starting a couple of departments of dermatology in 2 different medical colleges of Bengal. I graduated in medicine in 1989. That was about 3 decades and 33 years back. And from Burdwan, and after the mandatory internship of 1 year in different departments like internal medicine, psychiatry, and dermatology, I finally cracked the postgraduate entrance examination and shifted to the state capital of Calcutta. And my institute was the Institute of Postgraduate Medical Education and Research, that is IPGME, that happens to be one of the premier medical teaching institutes of our country. And you may be interested to know that the legendary Sir Ronald Ross worked in this hospital. Those days it was called the Presidency General Hospital, and became the first British Nobel laureate in 1902 for his path-breaking works on the transmission of malaria. And my dissertation topic, no points for guessing, was on mini grafting in vitiligo.
So you were carrying on a fine tradition in dermatology, and that's fascinating to hear about the Nobel Prize winner. And well, you certainly went on to build on that MD thesis. And I have to say, I thoroughly enjoyed reading your 2009 overview article in the Indian Journal of Dermatology on that concept of mini grafting. It's entitled The Evolution and Evaluation of Autologous Mini Punch Grafting in Vitiligo. And one of the things I loved about it, particularly as someone not working directly in this subspecialty area, was that you gave this fantastic historical overview at the beginning of the article to contextualize the problem of vitiligo. And I wonder if you could just outline for our listeners some examples of how vitiligo has been significant and how it has been recorded through the ages.
Vitiligo indeed is the most significant form of cutaneous acromia, as we all know as dermatologists. It is an elusive and enigmatic problem down the ages. And in all the ancient civilizations and religions, there is some reference to vitiligo. In our ancient text, that is Rig Veda, it was referred to as Kailas, and that means a white spotted deer. And even in ancient Persia, that is 2200 BC, at the time of Assyrian, in the Tariq Atibel Iran, it was also mentioned. And in Ebers Papyrus, 1550 BC, it was mentioned. Unfortunately, Dr. Walsh, some of the prominent ancient texts, the disease was actually confused with leprosy and also some other skin disease like psoriasis. In our ancient texts, like in Atharva Veda, that was 1400 BC, it was mentioned as Shweta Kushtha. And this Shweta, it is a Sanskrit term, it means white, and Kushtha means leprosy. So there you go. So from the very beginning, people started confusing with leprosy. Even in Shinto prayers, they have the mention, and in many ancient texts, it was mentioned and it was confused, unfortunately.
Well, yes, categorization of disease can be tricky. And I suppose what I loved about this is it showed that your surgical intervention is really a very modern solution for a very ancient problem. And regarding your current clinical work and the process of mini-grafting, I wonder, when I was reading through your body of literature, I was wondering about patient selection. And presumably when you meet patients, there are both clinical elements that you consider, such as disease extent, and also psychological elements. And so, for example, the degree of impairment of quality of life. And I wonder if you could give us a comment on how those two factors influence your patient selection.
Dr. Walsh, before coming to the topic, I think as we were discussing the evolution of the concept of vitiligo, it will be interesting for our listeners to know about the evolution of vitiligo surgery a little. So that will also be interesting because in 1804, about 220 years back, it was Baronio who first did the experimental skin grafting. And one surgeon, Dr. Norman Warentreich, in 1972, first reported the autograft repigmentation in human. And he turned a lady of dark complexion with long-standing leukoderma, which resulted from following a chemical burn many years back, when she was treated with a home remedy that included a copper penny dipped in vinegar with a tinea infection on her cheek. And Warentreich tried to treat that with 1 or 2 millimeter skin autograft. And that was the first time in our history the pigment spread phenomenon was noticed. Later on, there are many, many other workers. And one of the global giant and the father of vitiligo surgery considered to be Dr. Rafael Falabella, my guru, my mentor in this regard. Now coming to your question of how do we actually select the case? Before embarking any surgical intervention of vitiligo, a proper assessment of the stability status is of paramount importance, because it is not a fun if you like this the donor area is depigmented, the patient is active as per the disease process, and the donor area gets depigmented. It's very difficult to face the patient and the patient's family. So the concept was discussed in detail in many literature. What we do, very simply, we ask the patient from the history, any lack of progression of old lesions and an absence of development of any new lesion with a specific period, that is 6 months to 2 years. You know about the Kobner's phenomenon, either from the history or experimentally induced Kobner, or as Dr. Rafael Falabella he suggested, and we developed on that. That is test grafting. We do 1 or 2 grafts, place on the central of the lesion, and if the grafts are spreading pigment, then we consider this as a positive test graft, and then we go for further sessions of grafting.
So the timing is really critical, and making sure that the disease is not in a progressive phase. That's very interesting. And it sounds like is it a time-consuming procedure to perform? And can you give the listeners an idea of how long, for example, it would take to treat the area the size of, say, the palm of the hand?
Actually, you need to build up a team of trained nurses or assistants or juniors. I will take not more than 20 minutes. The smaller lesions I'll finish in 5 to 10 minutes. So that's all, because I have several people working on different places of the body. Someone is working on the donor area, taking up the donor grafts, and someone is preparing the recipient area, giving the infiltration of anesthesia and the recipient chambers. So simultaneously we can work, and that speeds up the procedure. Directly you can take the graft from the donor area, placed directly in the recipient area. I do not use any glue at all. It's a very fast, very, very easy procedure, and it gives a wonderful result.
Well, that was clear, certainly from the photographs I saw in your published papers. So it sounds like you've got it down to what we call in English a fine art, and speeding through the grafts. And can you tell me, do you get much post-operative bleeding when you're operating on sites like the vermilion lip, which, of course, as we know, is quite vascular?
Actually, Dr. Walsh, one of the best area to graft is on the lips and also on the upper eyelid. We have one of the largest series of grafting on the lips, and we use about lignocaine and mixed with adrenaline, that is 1 in 80,000 dilation, to enhance the duration of the anesthesia, to decrease the toxicity, to achieve the vasoconstriction, and to provide a bloodless field. Yes, so that was the magic. We definitely use adrenaline with lignocaine. I think I missed about the quality of life part, and yes, the quality of life in vitiligo. No, it is horrendous in most of our patients, and that is definitely one aspect. When suppose somebody is having a vitiligo patch, a lovely teenager girl, a boy having a patch of vitiligo, the segmental vitiligo on her cheek, so that can cause a really bad psychosocial effect, especially in the darker skin of our country. Any visible skin disorder can limit any healthy psychosocial engagement of an individual. He's shy, he's always introvert. So you can change his or her life with the touch of this small instrument that is the punch.
And do you routinely measure pre and post-operative quality of life?
Not really. It is not always needed, and it's not always possible also, honestly, in our busy practice schedule. But yes, in teaching hospitals for doing the research purpose, for any big papers, definitely these the dermatologic quality of life index, that is DLQI, is needed.
Yeah, and I guess we might infer certainly from the photographs that quality of life you would expect to improve after this intervention. And I wonder, could you give us a comment on the typical longevity of the results following the mini grafting?
Well, there is no rule of thumb. It depends. In segmental vitiligo, the result is good and long lasting, because as per the definition, as per the mechanism, the segmental vitiligo should not be that active, but not so in non-segmental vitiligo. And like a non-segmental vitiligo, it is again an enigma. Anytime it can become active. And I have seen all kinds of combination, like in stable vitiligo, I did the grafting. After 5 years, the graft started depigmenting, or even in active vitiligo, the pressure from the family. Suppose there is like a marriage in the family, or even that girl is getting married, we had to do the grafting even in active patient, and it was showing excellent result. So we are lucky, and the patient is lucky. And the typical longevity anytime between 2 to 10 years is considered as a success.
Fantastic. So really quite impressive results. And is there any adjuvant therapy that one can give to improve or enhance the likely longevity? You mentioned certainly in one of your publications that phototherapy is a very good post-operative treatment. And so perhaps a comment on that would be useful. And maybe also whether there's a role for things like topical steroids and topical tacrolimus.
That's an excellent question, Dr. Walsh. Topical calcineurin inhibitors are my first choice and my favorites, and definitely not topical steroid for its potential chance of being misused, especially in a country like ours, where these are all available over the counter. You'll be shocked to know the most potent topical steroid can be purchased over the counter. And the law enforcement may not be as what we wish it to be. So my first choice is definitely topical calcineurin inhibitor and exposing to narrowband UVB. We have completely stopped UVA unless the patient is having vitiligo lesion on the palms and soles, where you need the long waves to hit that area. Otherwise, narrowband UVB and topical calcineurin inhibitors are wonderful, actually.
Fantastic. That's a great clinical tip. And clearly therapeutics within this domain are, advancing all the time. And we've certainly seen that there's a role for JAK inhibitors in analogous autoimmune conditions like alopecia areata. But there is certainly some growing literature that the JAK inhibitors may also be useful as a treatment option in vitiligo. And I wondered if you had a comment on that, whether you had any clinical experience of it, and how you see JAK inhibitors evolving in a treatment role in this disease.
That's an exciting horizon we all are looking into, aren't we? Just a couple of months back, I think FDA has approved ruxolitinib cream for the treatment of non-segmental vitiligo in adult and pediatric patient over 12 years. I was reading one interesting article. I'm sure you have gone through this. That is the Frontiers in Immunology. It was published very recently in last week of August, where they have actually given a wonderful insight in how the JAK inhibitors can change our way of treatment in vitiligo. And there's we all know about the tofacitinib and ruxolitinib, but there's some tongue twister of the other JAK inhibitors, like the one is like a ritlecitinib. I'm sure you have heard about that. Or there is one that is brepoxitinib or serdulacitinib. And the funniest name is ifidamcitinib. That is so.
Certainly, there's no shortage of tongue twisters in the naming of these new medications.
I use a lot of the tofacitinib 5 milligram once or twice, and the results I can share. We are working on a big series, and it will be published. These are exciting. Ruxolitinib I have not used. These are actually topical. The 1.5% phosphate cream. Some results are very, very interesting, and this got the FDA approval. The others, the baricitinib and ifidamcitinib, that is reflexitinib, these are all some are oral medicines, some are topicals. These are very, very interesting horizon we are looking into.
Yeah, it's fascinating to hear of your experience with tofacitinib. So, Professor Lahiri, it has been such a privilege to talk to you, and I have learned a huge amount, as I'm sure our listeners have. You shared with me before we started recording that your son is starting medical school, so I hope that in the future he can continue this important seam of work that you've begun so successfully. So thank you to you, and thank you to our listeners for for tuning in to listen to this episode of the EADV podcast.
Thank you, Dr. Walsh, and thank you, EADV, for giving me the opportunity to be here. Thank you very much.
Save the date for our upcoming symposium hosted in Seville, Spain, 18th to the 20th of May 2023. Discover the latest scientific updates across acne, pigmentary disorders, atopic dermatitis, pediatric dermatology, and more. The symposium format offers you the chance to meet leaders in your specialty from all over Europe and beyond. Stay tuned for more. Thank you for listening, and until the next episode, take care of your skin.